Okay, let's unpack this. Welcome to the deep dive. Today we're really plunging into a crucial world of antibiotics, aminoglycosides and spectinomycin. Our mission isn't just, skimming the surface. We want mastery. We're going to dissect their molecular mechanisms, really unravel their intricate pharmacokinetics, and uncover the precise clinical applications. These are really powerful drugs. By the end of this, you should feel like you have that nuanced understanding, the kind that sets an elite professional apart. Our source material for this intensive exploration is KATZUNG's Basic and Clinical Pharmacology, a really renowned authority. And like I said, these aren't just any antibiotics. They're often the heavy artillery, right, reserved for the toughest bacterial foes. But like any potent tool, they come with, unique challenges and some truly fascinating science that really demands a deep understanding. To ground our discussion, let's think about a common clinical scenario. Imagine a 45-year-old burn patient. He's, say, 10 days into his ICU stay after extensive third-degree burns.
Now he's febrile, 39.5 Celsius, his white blood cell count has shot up dramatically, and he's had an episode of hypotension. Blood cultures are pending, but the team suspects Pseudomonas aeruginosa, a bloodstream infection. So they decide to start empiric combination therapy, and a critical part of that is tobramycin. This patient, let's say, weighs 70 kilos and has a pretty good creatinine clearance, estimated at 90 pmin. This is exactly the kind of complex decision point we'll be able to confidently navigate by the end of our deep dive. So let's jump in.
Okay, so what defines these aminoglycosides? What makes them so potent? Well, it's their fundamental classification. They are bactericidal inhibitors of protein synthesis. And that's not just, semantics. Bactericidal means they don't just halt bacterial growth like a bacteriostatic drug would. They actively kill the bacteria. This irreversible damage is really paramount in severe infections, especially in, say, immunocompromised patients or those with really rapidly progressing sepsis. And the mechanism, the killing effect, targets the very core machine or bacteria need for survival, their ability to synthesize proteins. Now, their primary utility, where they really shine, is predominantly against aerobic gram-negative microorganisms. That's their main playground. They often serve as crucial components in regimens for resistant gram-negative infections. The key players you'll hear about in this class, they include streptomycin, neomycin, kanamycin, amikacin, gentamicin, tobramycin, nettlemycin, and the newer one, plazomicin. Each one has its specific sort of strengths, but they all share this core bactericidal action against those aerobic gram-negatives. Now, in clinical practice, you rarely see aminoglycosides used as monotherapy for systemic infections. Almost never, really. They're almost invariably given in combination with other agents. And that strategy comes from both, efficacy and the need to combat evolving resistance. So for serious gram-negative bacterial infections, for example, they're commonly paired with a bot-lactam antibiotic. This combination gives you that broader empiric coverage, and importantly, it often leverages a critical synergistic effect. We can talk more about that. For gram-positive endocarditis, the combination might be with a bot-lactam or maybe vancomycin, really aiming for that maximal bacterial kill. And for mycobacterial infections, particularly tuberculosis, they are integral parts of multi-drug regimens, absolutely crucial for preventing rapid resistance and, achieving cure.
Right. So this isn't a standalone solution often, but a powerful team player. That tells us something profound right away about how they're used strategically in these complex infections. It really highlights that understanding antibiotic synergy is just as important as knowing the individual drug's profile.
Indeed. And what's truly foundational here to really understand these drugs is their unique molecular blueprint, their structure. Aminoglycosides have this characteristic hexose ring. For streptomycin, it's a streptidine ring. For most others, it's a 2-deoxystreptamine ring. And attached to these core structures are various amino sugars linked by glycosidic bonds. This sort of polycationic nature from all those amino groups, it's fundamental to how they interact with the negatively charged bacterial membranes and their subsequent uptake into the cell. The practical implications of this structure are pretty significant. They're highly water-soluble, which makes formulation for IV or IM administration easier. They also show remarkable stability in solution, which is a benefit for storage, obviously. But crucially, their activity is profoundly influenced by pH. They are significantly more active in alkaline conditions than in acidic environments, and this characteristic is directly linked to their transport mechanism into bacterial cells. A higher pH optimizes that transmembrane electrochemical gradient, enhancing their uptake and, consequently, their effectiveness.
Okay. So the very bones of these drugs, their structure, gives us really profound clues about their behavior and the best conditions for using them. It's like knowing the architecture of a building tells you about its integrity and where it functions best. It's a good reminder that chemistry really underpins all of pharmacology.
Precisely. And here's where we get into the real core of their power.
Yeah.
their mechanism of action, how they actually work. Aminoglycosides are irreversible inhibitors of protein synthesis. That word irreversible is key. It means their effect on the bacterial ribosomes is permanent. The bacterium can't recover. It leads directly to cell death.
Okay, irreversible.
Yeah.
But how do these molecules, which you said are highly polar, how do they even penetrate the tough defenses of a bacterial cell? It doesn't sound straightforward, given their structure and those barriers.
You're absolutely right. It's not simple. It's actually quite a sophisticated multi-step process, especially for gram-negative bacteria. First, the aminoglycoside has to passively diffuse through specific outer membrane channels. These are called porins. They're essential for allowing small hydrophilic molecules like these to get across that outer membrane.
Okay, so they get through the porins first.
Right. But just crossing the outer membrane isn't enough. The crucial step, the one that needs energy, involves active transport across the inner cell membrane into the cytoplasm. This uptake is driven by the cell's own transmembrane electrochemical gradient, basically, a proton motive force coupled to a proton pump. And this is why factors that diminish this gradient, things like low extracellular pH or anaerobic conditions, significantly inhibit transport, and that reduces the drug's effectiveness. Which brings us right back to why they're more active at alkaline pH. It optimizes that gradient. And what's even more critical, especially thinking about clinical synergy, is that this active transport step can be dramatically enhanced by cell wall active drugs, think penicillin or vancomycin. By disrupting the bacterial cell wall's integrity, these companion antibiotics basically open the door wider, allowing more aminoglycoside to get into the cytoplasm.
Ah, so that's the synergy. One drug helps the other get inside.
Exactly. That is the very basis of the potent synergy we see when these classes are used together. It leads to a killing effect that's truly greater than the sum of its parts. Okay, so once inside the bacterial cytoplasm, the aminoglycosides bind specifically to ribosomal proteins, on the 30S ribosomal subunit, to be precise. The ribosome, of course, is the cell's factory. It translates the genetic code from mRNA into functional proteins. Aminoglycosides don't just inhibit this factory, they launch this multi-pronged, devastating attack that simultaneously disrupts protein synthesis in at least 3 distinct ways. It ultimately leads to irreversible damage and cell death. So first, they interfere with the very start of the process, the initiation complex of peptide formation. This basically means they prevent the ribosome from correctly assembling at the start signal on the messenger RNA, so the protein production line can't even begin.
Blocks it right at the starting gate.
Pretty much. Second, and this is perhaps their most famous mechanism, they cause profound misreading of mRNA. This leads to the wrong amino acids being incorporated into the growing peptide chain. The result, non-functional proteins, truncated proteins, maybe structurally abnormal proteins.
Typo effect, right. Generating junk proteins.
Exactly. These faulty proteins can't do their jobs, and sometimes these misfolded proteins can even get inserted into the bacterial cell membrane, further messing up its integrity and actually worsening the gradient disruption needed for drug transport. It becomes a kind of vicious cycle. And third, they cause the breakup of polysomes into non-functional monosomes. Now, polysomes are these efficient assemblies, multiple ribosomes working on one mRNA strand simultaneously, churning out lots of protein copies fast.
Like a production line?
A very efficient one. Aminoglycosides disrupt this system. They cause these polysomes to break apart into single non-functional ribosomal units. This effectively dismantles the bacterium's ability to mass-produce proteins, profoundly inhibiting its growth and survival. So these 3 distinct but simultaneous mechanisms, they ensure this comprehensive, irreversible shutdown of bacterial protein synthesis. That leads to rapid, devastating bacterial cell death. It's not just, one wrench in the works. It's a whole toolbox thrown in, causing a cascade of systemic disruption.
Wow, that truly underscores the complexity. It's less about one single point of attack and more like a systemic failure of the bacteria's core machinery. Does that inherently make resistance harder for bacteria to develop? Or is it maybe a double-edged sword they can find ways around?
Oh, it's definitely a constant arms race. Bacteria are incredibly adaptable. And despite this multi-pronged attack, they have evolved sophisticated defense mechanisms. We've basically established 3 principal mechanisms of resistance that bacteria use to fight back against aminoglycosides. It's a real testament to that ongoing evolutionary pressure. The first mechanism, and this is by far the most common type of resistance we see in clinical settings, involves the production of a transferase enzyme. These enzymes are like molecular saboteurs. They chemically modify the aminoglycoside to inactivate it. They do this through processes called adenylation, cetylation, or phosphorylation. They stick chemical groups onto specific spots on the aminoglycoside molecule. If you look at, say, the structure of gentamicin in the source material, KATZUNG's figure 45-2, there are circled numbers showing exactly where these bacterial enzymes attack the drug. These chemical changes fundamentally alter the drug's shape so it can't bind properly to the ribosome anymore. Or sometimes it even prevents it from getting into the cell properly.
So the bacteria basically disarm the weapon before it hits the target.
That's a great analogy, yes. The second mechanism is impaired entry of the aminoglycoside into the cell. Bacteria can do this in a couple of ways. They might develop mutations or even delete the genes for their porine proteins. Those channels we talked about making the outer membrane less permeable.
Blocking the door.
Essentially, yes. Or resistance can arise just from the growth conditions themselves if they compromise that oxygen-dependent active transport process, like in really anaerobic environments or places with very low pH. So the bacterium either builds a stronger wall or it disrupts the energy supply needed to actively pump the drug inside. And the third mechanism, which is generally less common, involves a modification of the ribosomal target itself. This happens when the receptor protein on the 30S ribosomal subunit, the specific spot where the aminoglycoside needs to bind, gets deleted or its shape is altered because of a genetic mutation.
Changing the lock.
Exactly. If the drug's target changes shape or isn't there, the aminoglycoside just can't bind effectively. It becomes useless. So, yeah, bacteria are constantly evolving these defenses, dismantling the weapon, blocking the door, or changing the lock.
It's a continuous, really dynamic battleground.
Yeah.
And this constant adaptation by bacteria just underscores, how urgent prudent antibiotic stewardship really is. If we're not careful, they'll always find a way to outsmart us.
Absolutely. It's a relentless challenge. Now, shifting gears slightly, understanding how these drugs are handled by the body, their pharmacokinetics, is equally critical. It's crucial for optimizing treatment, sure, but just as importantly for mitigating their inherent toxicities. This knowledge dictates everything: administration routes, dosing, monitoring strategies. So when it comes to absorption and administration, a really key characteristic is that aminoglycosides are absorbed very poorly from an intact GI tract. What that means practically is that taking them orally just doesn't work for systemic infections. Almost the entire oral dose just passes right through and comes out in the feces.
Okay, so no pills for a bloodstream infection.
Right. However, there's a crucial clinical caveat here. If there are ulcerations or significant inflammation in the GI tract, some systemic absorption can occur, and that can lead to unexpected toxicity. So given that poor oral bioavailability for systemic effects, aminoglycosides are typically given intravenously, usually as a 30-60-minute infusion. Or they can be given via intramuscular injection. They're well absorbed that way too, and you get peak blood concentrations within about 30 to 90 minutes. And interestingly, the peak serum levels after an IM shot are pretty much identical to those after an ID infusion, so both routes are viable for systemic delivery. Now, in patients with normal kidney function, the elimination half-life, how long it takes for half the drug to leave the body, is relatively short, usually around 2 to 3 hours. But, and this is a huge but, this is profoundly altered if there's renal impairment. The half-life can dramatically stretch out to 24, even 48 hours.
Wow, that's a massive difference.
It is, and it absolutely necessitates careful dose adjustments to prevent the drug from building up to toxic levels. It's also important to know they're only partially and irregularly removed by hemodialysis. For gentamicin, maybe 40–60%, and even less effectively by peritoneal dialysis. So dialysis isn't really a quick fix if someone gets overdosed or the drug accumulates badly. And in terms of tissue penetration, remember we said they're highly polar compounds.
Right, water-soluble.
Which means they don't easily cross lipid membranes or get into cells readily. Consequently, they're largely excluded from certain body compartments. Most notably, the central nervous system, the brain and spinal fluid, and the eye. This limited penetration directly impacts where we can use them. They're generally ineffective for infections in these sanctuary sites.
Excellent.
There are exceptions, though. If there's active inflammation, like in meningitis, the CSF levels can reach maybe 20% of plasma levels, even higher in neonatal meningitis. But to get really high therapeutic levels in the CNS, you often need specialized administration, like injecting it directly intrathecally or intraventricularly. Outside the renal cortex, where they do tend to accumulate, systemic levels aren't generally high in most other tissues. Concentrations and secretions are also pretty modest. Bile levels might only be 30% of blood levels. Although with prolonged therapy, they can diffuse into certain body fluids, like pleural or synovial fluid, maybe reaching 50–90% of plasma levels over time.
So their inherent polarity, their very molecular design, fundamentally dictates where these drugs can and cannot effectively reach. It's such a powerful reminder that drug delivery and distribution are just as critical as the drug's mechanism of action itself. You can have the best weapon, but if you can't get it to the battlefront, right, it's useless.
Precisely. And this leads us nicely into maybe one of the most significant evolutions we've seen in aminoglycoside therapy, the shift in dosing strategies.
Yeah, historically, these drugs were given multiple times a day, right? Like 2 or 3 times daily. But there's been this big paradigm shift towards once daily dosing. Now, for an antibiotic, where you usually think about maintaining consistent drug levels above the MIC, this seems really counterintuitive. What's the science driving this profound change in practice? Why go to once a day?
This is a prime example of where understanding pharmacodynamics, how the drug interacts with both the bacteria and the body, becomes absolutely paramount. The move to once-daily dosing is fundamentally driven by 2 unique pharmacological properties of aminoglycosides that kind of defy conventional antibiotic wisdom. The first is something called concentration-dependent killing. Unlike some other antibiotic classes where efficacy is more tied to the duration the drug stays above a certain concentration, the minimal inhibitory concentration, or MIC.
Time above MIC, yeah.
Yeah, right. With aminoglycosides, they actually exhibit enhanced bacterial killing as their concentration increases. Higher peak concentrations lead to a more rapid and a more extensive kill of bacteria. So think of it less like a prolonged siege and more like delivering a single powerful, decisive knockout punch to the pathogen. The height of that peak concentration matters more than how long it stays above the MIC. The second, equally crucial property is a significant post-antibiotic effect, or PAE. This refers to the persistent suppression of bacterial growth that actually continues even after the drug concentration in the body has fallen below that measurable MIC.
So even when the drug seems gone, it's still having an effect.
Exactly. For aminoglycosides, this lingering lethal effect can last for several hours. The bacteria are still damaged, still unable to resume normal growth and division, long after the drug appears to have washed out from the bloodstream. So because of this unique combination concentration-dependent killing and a robust post-antibiotic effect, a given total amount of aminoglycoside, when administered as a single large daily dose, can actually achieve better efficacy and, surprisingly, less toxicity compared to giving that same total dose divided into multiple smaller administrations throughout the day.
Wow, okay. Better efficacy and less toxicity with one big dose. That really does reshape how you'd approach using them.
It fundamentally does. It favors an intermittent, high-impact exposure strategy. And this also brings us back nicely to synergy and combination therapy. Remember we said when you co-administer aminoglycosides with a cell wall active antibiotic like a vorlactam or vancomycin?
Yeah, they help each other.
They can exhibit a truly synergistic killing effect against certain bacteria. And this isn't just additive. The combined killing activity is significantly greater than the sum of their individual effects. The cell wall agent helps more aminoglycoside get into the cell, allowing it to hit the ribosome harder. This synergy is particularly vital in really tough situations like endocarditis, where you absolutely need maximal bacterial killing for a successful outcome. Now let's talk toxicity, because that's a major concern with these drugs. Adverse effects are considered both time and concentration dependent. What that means is, while yes, you need to reach a certain threshold concentration for toxicity to even start, once you cross that threshold, the cumulative time the drug concentration stays above that level becomes critical for developing side effects. For instance, we generally consider a trough concentration, the lowest level, just before the next dose exceeding 2 millicg/ml, as predictive of increased toxicity risk.
Okay, so you don't want the level staying high for too long between doses?
Exactly. And here's the key advantage of once-daily dosing regarding toxicity. At clinically relevant doses, the total time the drug concentration remains above that potential toxic threshold is actually shorter with a single large dose compared to multiple smaller doses. That single large dose allows for a more extended washout period, where drug levels drop really low, even undetectable. This significantly reduces the cumulative exposure to potentially harmful concentrations and gives the body's cells, particularly in the kidneys and ears, a chance to recover. And indeed, numerous robust clinical studies studies have consistently shown that a single daily dose of an aminoglycoside is not only just as effective, but also likely less toxic than giving the same total daily dose in multiple smaller increments. As a result, many leading authorities now recommend once-daily aminoglycoside administration in most clinical situations.
So it's become the standard approach for many cases?
For many, yes. But it's important to acknowledge specific exceptions or areas where the data are still maybe evolving or less clear. For example, in combination therapy for enterococcal endocarditis, and particularly for staphylococcal endocarditis involving a prosthetic heart valve, traditional lower doses given 2 or 3 times daily are often still recommended, though limited data do support once-daily dosing for streptococcal endocarditis. Furthermore, the optimal dosing strategy in specific populations like pregnant patients, individuals with obesity, or neonates remains less clearly defined. So, often traditional dosing might be preferred in those cases out of caution. But from a practical standpoint, adopting once-daily dosing offers several really compelling advantages. It significantly cuts down on the need for frequent therapeutic drug monitoring. Those repeated serum level checks, usually mandatory with these drugs, become unnecessary unless therapy goes beyond about 3 days or the patient's renal function changes.
That saves time and resources.
Absolutely. It's considerably less labor-intensive for nursing staff, improving workflow, and critically, once-daily dosing makes outpatient therapy much more feasible. It could potentially allow patients to get essential treatment at home instead of needing a prolonged hospital stay. Now, given that aminoglycosides are almost exclusively cleared by the kidneys, their excretion rate is directly proportional to the patient's creatinine clearance, our main measure of renal function. This direct relationship is the absolute cornerstone of all dosing adjustments.
Makes sense. Kidney function is key.
It's paramount. So to prevent drug accumulation and those associated toxic levels, once daily dosing is generally avoided if a patient's renal function is significantly impaired. And moreover, in situations like acute kidney injury where renal function can change rapidly, you need meticulous, frequent monitoring to prevent both overdosing and underdosing. But when these critical factors are carefully managed, once daily dosing is both safe and highly effective. So for patients with normal renal function, let's define that as a creatinine clearance greater than 60 millioelmin. The recommended once-daily dose for gentamicin or tobramycin is 5-7 mg/kg. For amikacin and the newer plazomicin, the recommended single daily dose is higher at 15 mg/kg.
Okay, higher dose for those two.
Yes. But for patients with impaired renal function, where creatinine clearance drops below 60 millioelmin, the traditional multiple dose regimens are typically favored. That's because of the increased risk of accumulation with large single doses. A unique aspect of plazomicin, though, is that its clinical development and approval were based solely on an extended or once-daily dosing strategy, so traditional twice or thrice daily regimens just don't apply for plazomicin. Now, when you are using once-daily dosing, routine serum concentration monitoring usually isn't needed until the 2nd or 3rd day of therapy. Depends on how stable the patient's renal function is and how long you expect treatment to last. In most situations, it's actually unnecessary to routinely check peak concentrations with once-daily dosing.
Really? No peak check?
Generally, no. An exception might be in really challenging infections, say with highly drug-resistant bugs, where you absolutely want to ensure you're hitting a sufficiently high peak concentration for optimal killing. The primary goal for monitoring once-daily dosing is to ensure that the trough concentration, the lowest level right before the next dose, is less than 1 mg/ml. You want that measurement taken between 18 and 24 hours after the dose. This confirms you've had sufficient drug washout, minimizing the time the patient is exposed to those potentially toxic cumulative levels. Clinicians can use validated tools like the Freeman reference or the Hartford nomogram to help calculate these once-daily doses. In stark contrast with traditional multiple dose strategies, giving the drug 2 or 3 times a day, meticulous adjustments are absolutely essential in patients with kidney problems. You have to prevent accumulation. This is usually done by either keeping the dose constant and increasing the interval between doses, or keeping the interval the same and reducing the individual dose size. There are nitograms and formulas to help with this based on serum creatinine. And for a traditional twice or thrice daily regimen, the monitoring is much more rigorous and timing is critical. You need peak serum concentrations drawn 30-60 minutes after a dose. For gentamicin and tobramycin, the target peak is usually 5 to 10 millisieverts/ml. Often you aim for the higher end, maybe 8 to 10, in more serious infections to really maximize killing. And you also need trough concentrations drawn just before the next dose. For gentamicin and tobramycin, the critical goal here is to keep those trough levels below 2 millisieverts/ml and ideally less than 1 millisieverts/ml. Keeping those troughs low directly correlates with minimizing toxicity risk.
This detailed look at dosing just reveals such a sophisticated dance, doesn't it? Between maximizing bacterial eradication and minimizing patient harm. And that evolution towards once-daily dosing, driven by such a deep understanding of these unique KKPD principles, it really exemplifies how clinical practice adapts to scientific insight. It's not just about following rules. It's truly understanding the underlying science that dictates those rules.
Absolutely. And with great potency, inevitably comes the need to understand the potential collateral damage. When we discuss aminoglycosides, we primarily focus on two major adverse effects: ototoxicity and nephrotoxicity, ear toxicity and kidney toxicity. And it is a fundamental truth that all aminoglycosides carry the inherent risk of causing both of these serious toxicities. Now, these adverse effects aren't just random. Their likelihood significantly increases under specific conditions. First, therapy that's prolonged beyond about 5 days dramatically elevates the risk. Second, higher doses are directly correlated with increased toxicity. Makes sense. Third, certain patient characteristics make people more susceptible. The elderly, for instance, are more vulnerable, as are patients who already have some degree of renal insufficiency.
So patient factors matter a lot.
Immensely. And lastly, using aminoglycosides at the same time as certain other medications can profoundly potentiate nephrotoxicity. This includes loop diuretics, think furosemide, bumetanide, or ethacrynic acid, or other known nephrotoxic antimicrobials like vancomycin or amphotericin. Whenever clinically possible, you really want to avoid these combinations. Or, if absolutely necessary, use them with extreme caution and much more intensive monitoring. Let's delve into ototoxicity first. This side effect can show up in two distinct ways, reflecting damage to different parts of the inner ear. You can have auditory damage. This usually starts as tinnitus, that ringing or buzzing in the ears, and then can progress to a loss of high-frequency hearing. Or you can have vestibular damage. This affects the organ of balance and results in symptoms like vertigo, ataxia, which is a loss of coordination, and just a general profound sense of imbalance.
And the really scary part about ototoxicity is
its tendency to be irreversible. That's the critical, often tragic characteristic. Once the damage to the delicate hair cells of the inner ear occurs, it is typically permanent. And furthermore, emerging research suggests some susceptibility might be genetic, linked to specific point mutations in mitochondrial DNA, the incidence. It's reported in roughly 1 to 5% of patients receiving gentamicin for more than 5 days. Then there's nephrotoxicity, targeting kidney function. This is usually picked up through objective measures like rising serum creatinine levels or a drop in the estimated glomerular filtration rate, the eGFR. Although sometimes a more subtle earlier sign can actually be an increase in the trough serum aminoglycoside levels. That signals the drug is accumulating because the kidneys aren't clearing it properly.
But unlike the ear damage, kidney damage is
Usually reversible. That's a key difference. If it's caught early and the aminoglycoside is stopped promptly, kidney function often recovers. The incidence of nephrotoxicity is higher than ototoxicity, affecting somewhere between 5% and 25% of patients getting gentamicin for longer than about 3 to 5 days. If you see signs of nephrotoxicity, it requires, at the very least, an immediate adjustment of the dosing regimen, and it should really prompt a thorough reconsideration. Do we absolutely need this drug, or is there a less toxic alternative available? Meticulous measurement of serum levels, especially troughs, is absolutely essential in managing this risk.
So they're incredibly effective, potentially life-saving drugs, but their administration is such a delicate balancing act, balancing profound efficacy against these serious, potentially irreversible side effects. It's that quintessential risk-benefit calculation that just demands continuous vigilance and a truly deep understanding in clinical medicine.
Indeed. And while all aminoglycosides share these fundamental risks, their individual toxicity profiles do have some nuances. For instance, neomycin, kanamycin, and amikacin seem to be the agents most frequently associated with auditory damage, hitting hearing more prominently. In contrast, streptomycin and gentamicin are considered the most vestibulotoxic, primarily affecting balance. And regarding nephrotoxicity, kidney damage, neomycin, tobramycin, and gentamicin are the ones most often implicated. Now, plazomicin, being the newest aminoglycoside, shows a promising, although still limited, toxicity profile. Clinical experience is still accumulating, but early data suggest it might be associated with lower rates of ototoxicity and nephrotoxicity compared to the older agents.
That's good news.
It is. For example, in initial trials, no ototoxicity or nephrotoxicity was actually observed. However, a later phase 3 trial did note higher rates of renal-related adverse effects in the plazomicin group, about 3.6%, compared to the comparator meropenem, which was 1.3%. But crucially, most participants who experienced nephrotoxicity with plazomicin showed full renal recovery. So that adds an important layer of nuance to its safety profile. Promising, but needs continued monitoring. Beyond those critical twin toxicities, aminoglycosides can cause other adverse effects, though some are less common. One rare but extremely serious effect is neuromuscular blockade. At very high doses, aminoglycosides can produce this cure-like effect, inhibiting nerve muscle transmission and potentially leading to profound respiratory paralysis. It's a medical emergency.
Needs immediate intervention.
Absolutely. Fortunately, this paralysis is usually reversible with specific antidotes like calcium gluconate, if given promptly, or neostigmine. A historical but illustrative example was when sudden, large-scale absorption of kanamycin, like 3 to 5 grams, from the peritoneal cavity after surgery, actually resulted in this Curer-like blockade and respiratory arrest. Hypersensitivity reactions, things like fever, skin rashes, other allergic phenomena, they're infrequent with aminoglycosides, but they can happen. They seem to occur most often with prolonged courses of treatment, like those used for tuberculosis. Pain at the injection site is also pretty common, especially with streptomycin, though usually not severe. A critical specific warning pertains to streptomycin. If it's given during pregnancy, it carries a significant risk of causing deafness in the newborn. That demands extreme caution and careful risk-benefit analysis.
Absolutely critical warning.
And finally, for topical formulations, particularly neomycin-containing ointments used on skin and eyes, you can get localized irritation or allergic reactions, often due to sensitization with repeated use.
These powerful tools clearly come with a really complex safety profile. Understanding these potential side effects and the vigilance required in monitoring is just as critical as knowing their primary action. It's truly a testament to the comprehensive knowledge clinicians need to wield effectively. So given this now very nuanced understanding of their strengths and weaknesses, how exactly are these drugs strategically deployed within our medical arsenal? Where do they fit?
That's the crucial pivot, right? Translating all this understanding into action. Aminoglycosides are predominantly reserved for combating serious infections, usually caused by aerobic gram-negative bacteria, especially in situations where drug-resistant pathogens are a concern, or in critically ill patients where you need rapid, potent bactericidal activity right now. That's their definitive clinical niche. And as we've really emphasized, combination therapy is almost always the rule for systemic infections. For example, tobramycin and gentamicin are nearly always used in combination with a like-term antibiotic. This strategy broadens the empiric coverage. That's our initial antibiotic choice before we get definitive culture results back, and it strategically exploits that potential synergy between the two classes where the lactam helps the aminoglycoside get in.
Right, boosting each other's effect.
Exactly. Similarly, amikacin and streptomycin are frequently combined with other antibacterials, particularly for those multi-drug regimens essential in treating microbacterial infections like TB. For plazomicin, the newest agent, its role in combination therapy versus potentially being used alone is still being sort of defined as more clinical experience accumulates. Historically, penicillin and aminoglycoside combinations were also a mainstay for achieving bactericidal activity in treating enterococcal endocarditis, and also for shortening therapy duration for virulent streptococcal endocarditis. However, it's vital to acknowledge how clinical practice evolves. Due to their significant toxicity profiles, these aminoglycoside-containing combinations are used less frequently today, especially when equally effective but less toxic alternative regimens become available.
So safer options have emerged.
Exactly. For instance, in enterococcal endocarditis, more recent studies suggest that combining ampicillin and ceftriaxone provides an effective regimen with a significantly lower risk for nephrotoxicity compared to older regimens that included an aminoglycoside. This really exemplifies how guidelines shift as new evidence and safer alternatives emerge. Ultimately, when aminoglycosides are selected, the specific agent and its precise dose are meticulously chosen based on the infection severity, the suspected or confirmed pathogen, and importantly, the susceptibility profile of that isolated microorganism.
So it's not a rigid algorithm at all, but a highly targeted, precisely tailored therapy that requires constant reevaluation based on the patient and the bug. This strategic application of deep pharmacological knowledge is exactly the kind of understanding we're aiming for here. Now let's bring it back. Let's revisit our burn patient from the ICU, that 45-year-old with a suspected Pseudomonas aeruginosa bloodstream infection. Remember, he weighs 70 kilograms and has a good creatinine clearance of 90 mmHg. How exactly should tobramycin be dosed for him, and what specific monitoring strategies should be put in place? Let's apply what we've learned.
Excellent. This is where we synthesize all those principles. Our patient presents with normal renal function, right? CRCL of 90 mmHg. That crucial piece of information means he is an ideal candidate for once-daily dosing, which, as we've established, is generally preferred because of its comparable efficacy and that reduced toxicity profile driven by concentration-dependent killing and the post-antibiotic effect. So for tobramycin, using the once-daily strategy, we would administer a single intravenous injection. The dose is 5 to 7 milligrams. For our 70-kilogram patient, this translates to a single daily dose ranging from 350 milligrams up to 490 milligrams, infused over 30 to 60 minutes.
Okay, 350 to 490 milligrams once a day.
Correct. Now, in terms of monitoring for this once-daily regimen, the primary focus is really on ensuring adequate drug washout to minimize toxicity. A single serum level measurement taken approximately 8 hours after the infusion can be valuable. We'd aim for a level somewhere between 1.5 and 6 millicg/ml. If the level falls in that range 8 hours post-dose, it generally correlates well with an appropriate trough level later on, meaning sufficient drug has been cleared before the next dose is due, minimizing that risk of cumulative toxicity. Routine peak concentrations, as we said, generally aren't needed for once-daily dosing unless there's a very specific concern about underdosing for a highly resistant pathogen. Now, alternatively, if the clinical decision for some reason favored a traditional dosing strategy, you could take that same total daily dose, 350, 490 milligrams, divide it into smaller equal amounts and administer it every 8 hours. The traditional way, yes. But with this traditional multiple dose regimen, meticulous monitoring of both peak and trough concentrations becomes absolutely essential. The target peak concentration measured 30-60 minutes after a dose would be between 5 and 10 millicity/ml. And you'd likely aim for the higher end, maybe 8 to 10, given the severity of a suspected Pseudomonas bloodstream infection. And the target trough concentration, measured just before the next dose, absolutely must be less than 2 millicg/ml, and ideally less than 1 millicg/ml. Maintaining these low trough levels is critical to prevent drug accumulation and mitigate those dose and time-dependent toxicities like nephrotoxicity.
This is truly what it means to be an elite professional, isn't it? To take a complex clinical scenario like this and confidently apply these detailed pharmacological principles, understanding the why behind each strategic choice in dosing and monitoring. It's not just following a guideline, it's deeply understanding the intricate underlying science that dictates that guideline.
Exactly right. Now, let's go even deeper. Let's examine the specific nuances of some of the individual aminoglycoside agents, and we'll also touch on spectinomycin at the end. Each one possesses unique characteristics, specific strengths, and defined limitations that really shape its particular place in our therapeutic armamentarium. First up, streptomycin. Isolated way back from Streptomyces griseus, it was one of the earliest aminoglycosides discovered. Its core antimicrobial activity is typical of the class, but its real Achilles heel is that resistance, particularly ribosomal resistance, emerges readily. Quite easily, in fact. This severely limits its current utility as a single agent for most infections these days.
So resistance is a major issue for streptomycin.
A major issue. Because of this, streptomycin's primary role today is as a crucial second-line agent for treating tuberculosis. But importantly, it is always used in combination with other anti-TB drugs to prevent that rapid resistance selection. The typical adult dosage for TB is 15 millikilograms per day, usually maxing out at 1 gram per day, given IM or IV. For kids, it's 20-40 millikilograms per day. Beyond TB, streptomycin still retains some specific niches. It's used for certain non-tuberculous infections like plague, tularemia, sometimes brucellosis, often combined with an oral tetracycline. And it still holds a critical, though limited, role in specific cases of endocarditis. While gentamicin is generally preferred now, penicillin plus streptomycin combinations were historically effective for enterococcal and viridans streptococcal endocarditis, sometimes allowing for shorter 2-week regimens. What's particularly important here is that streptomycin retains activity against some enterococcal species that are resistant to gentamicin and therefore also resistant to nettlemycin, tobramycin, and amikacin.
Why is that?
It's due to a specific bacterial enzyme, a bifunctional enzyme that inactivates gentamicin and the others, but not streptomycin. So this provides a unique alternative agent for those specific gentamicin non-susceptible enterococcal infections. In terms of adverse reactions, hypersensitivity fever, skin rashes can occur, especially with prolonged courses like for TB. Pain at the injection site is common, but the most serious toxic effect specific to streptomycin is profound and often irreversible disturbance of vestibular function leading to vertigo and loss of balance. Its severity correlates with age, blood levels, duration of therapy. And critically, that stark warning we mentioned, streptomycin given during pregnancy can cause deafness in the newborn. Okay, next we have gentamicin. This agent is actually a mixture of 3 closely related constituents, C1, C1a, and C2, derived from Micromonospora purpurea. It's a real workhorse in the class. It has broad activity against both gram-positive and gram-negative organisms, including the tough ones like Pseudomonas aeruginosa and members of the Enterobacterales family. It also hits many Staphylococci. But remember, like all aminoglycosides, it has no activity against anaerobes. That's a key limitation.
Right? Aerobic bugs only.
Exactly. Now, resistance patterns are crucial for gentamicin. Streptococci and enterococci are relatively intrinsically resistant because the drug doesn't get into their cells very well. But this is precisely why synergy with penicillins or vancomycin is so potent. Those cell wall agents help it get inside. With Staphylococci, resistance during monotherapy can emerge rapidly through permeability mutants, though ribosomal resistance is rare. For gram-negative bacteria, the most common resistance mechanism is those plasmid-encoded modifying enzymes we talked about. Notably, gram-negative strains resistant to gentamicin are often still susceptible to amikacin, which is less vulnerable to many of those enzymes. And that key nuance for enterococci again, that specific bifunctional enzyme that inactivates gentamicin often also inactivates amikacin, nettlemycin, and tobramycin, but not streptomycin. That explains streptomycin's unique niche. Gentamicin's clinical uses are mainly via IM or IV administration for severe infections caused by gram-negatives likely resistant to other drugs. Think P. aeruginosa, Enterobacter, Serratia, Proteus, Acinetobacter, Klebsiella. It's almost always used in combination with a second agent because monotherapy often isn't effective enough for infections outside the urinary tract. And critically, gentamicin and other aminoglycosides should not be used as single agents for treating pneumonia. Penetration into infected lung tissue is poor, and the local conditions there, low pH, low oxygen, limit their activity.
That's a really important point about pneumonia.
Very important. Dosing, as we said, is typically 5-7 mg/d, traditionally given in 3 divided doses, but now often once daily. It also plays a role in combination therapy for gram-positive endocarditis. Beyond systemic use, gentamicin has topical and ocular applications. You'll find 0.1, 0.3% creams, ointments, solutions used for infected burns, wounds, skin lesions, sometimes even for trying to prevent IV catheter infections, though effectiveness there is unclear, and it gets partly inactivated by pus. Intraocular injections are used for severe eye infections. Intrathecal administration, injecting it into the spinal fluid for gram-negative meningitis, was once used, 1 to 10 mg/d, but its utility now is very limited. Toxicity, especially in neonates, and the superiority of third-gen cephalosporins have largely made it obsolete, except maybe for highly drug-resistant cases or severe lactam allergy. Its adverse reactions are the classic ones. Nephrotoxicity, 5-25% incidence, usually reversible, needs monitoring. And ototoxicity, 1-5% incidence, mainly vestibular, irreversible, partly genetic. Hypersensitivity is uncommon.
Gentamicin really is a workhorse, but clearly a demanding one. Its broad activity makes it so valuable, but its limitations and those significant risks mean constant vigilance, and a deep understanding of all its nuances are absolutely required.
Next up, tobramycin. Its antibacterial spectrum is remarkably similar to gentamicin's. While there is some cross-resistance between them, it's unpredictable, which means you always need separate lab susceptibility tests for the specific bacterial isolate you're dealing with. You can't just assume.
Can't interchange them without checking the bug's sensitivity first.
Precisely. Its pharmacokinetics and dosing are virtually identical to gentamicin's. Same daily dose, 5-7 mg/kg IM or IV. And like gentamicin, it's now often given as a single daily dose. But meticulous monitoring, especially with renal impairment, is essential. The key differentiating nuances in their activity are subtle but can be important clinically. Gentamicin is slightly more active against Serratia marcescens, whereas tobramycin holds a slight edge against Pseudomonas aeruginosa, and that can be a critical distinction for such a notoriously difficult pathogen.
So Tobra might be slightly better for Pseudomonas.
Slightly, yes. Also, while Enterococcus faecalis is susceptible to both, Enterococcus faecium is resistant to tobramycin, but otherwise they are largely interchangeable clinically. Tobramycin shares the same ototoxic and nephrotoxic profile, although some data suggest its nephrotoxicity might be marginally less than gentamicin's. But tobramycin has some unique and really impactful administration routes beyond the standard IVIM. It's formulated specifically for inhalation, a 300 mg and 5 mg solution, to treat Pseudomonas aeruginosa lower respiratory tract infections in patients with cystic fibrosis.
That's a huge application.
It is. The dosage is a fixed 300 mg twice daily, regardless of age or weight, and it's given in repeated cycles, 28 days on therapy, followed by 28 days off. Systemic absorption via inhalation is minimal. Serum concentrations stay very low, around 1 mmHg/ml. So consequently, nephrotoxicity and ototoxicity are rarely seen with this inhaled route, though caution is still advised if the patient has pre-existing kidney, balance, or hearing problems. Tobramycin is also available as a 0.3% ophthalmic ointment and drops for superficial eye infections. Again, minimal systemic absorption, negligible systemic side effects.
This really highlights how even slight differences in activity profiles, combined with innovative formulations, can carve out crucial, highly specialized niches for these drugs. That inhaled form for cystic fibrosis is just a prime example of targeted therapy innovation, delivering the drug right where it's needed with minimized systemic risk.
Moving on to amikacin. This one is a semi-synthetic derivative of kanamycin, and importantly, it's less toxic than its parent molecule. Amikacin's most significant strength, its real claim to fame, lies in its resistance profile. It is remarkably resistant to many of those bacterial enzymes that typically inactivate gentamicin and tobramycin.
So it works when the others might not.
Exactly. This makes it a critical option against microorganisms that have developed resistance to those more commonly used aminoglycosides. Amikacin inhibits a broad range of gram-negative bacteria, including many strains of Proteus, Pseudomonas, Enterobacter, and Serratia, usually at MICs of 120 mg/ml. Standard dosing might be 500 milligrams every 12 hours, totaling 15 millinome per day given II. This usually results in peak serum levels between 10 and 30 millicg/ml. One of its most important clinical applications today is against strains of multi-drug-resistant Mycobacterium tuberculosis, including those resistant to streptomycin. It's worth noting, though, that strains resistant to kanamycin might show cross-resistance to amikacin. For TB treatment, the dosage is typically 10-15 millidigens per day, given as a once-daily dose, or maybe twice or thrice weekly injection. And again, always used in combination with other active anti-TB drugs. Like all aminoglycosides, amikacin is both nephrotoxic and ototoxic. It seems to have a particular propensity for affecting the auditory portion of the eighth cranial nerve, potentially leading to hearing impairment more than balance issues. Given its toxicity profile and the higher target concentrations we aim for, vigilant monitoring of serum concentrations is absolutely essential. For an every 12-hour dosing regimen, the target peak serum concentrations are higher than for gentamicin or tobramycin, typically aiming for 20-40 mcg/ml, and trough levels should be maintained between 4 and 8 mcg/ml.
Amikacin is clearly our strategic heavy hitter when we're facing down resistance to the other common aminoglycosides. It's just a powerful demonstration of how targeted chemical modifications can profoundly broaden a drug's utility and provide a critical lifeline when other options have failed.
Next, let's briefly mention nettlemycin. This agent shares many characteristics with gentamicin and tobramycin. Its unique structural advantage was the addition of an ethyl group at a specific position on the molecule. This modification sterically protected nettlemycin from being broken down by some of the bacterial enzymes that target gentamicin and tobramycin.
So smart chemistry to beat resistance.
Exactly. Consequently, nettlemycin retained activity against some bacteria resistant to gentamicin and tobramycin. Its dosage, 5-7 mg/GAD, and administration routes were the same as gentamicin's, and clinically it was largely interchangeable. However, it's relevant for our listeners in the U.S. that nettlemycin is no longer available here. Just highlights the dynamic nature of which drugs are on the market at any given time.
Yeah, that's a fascinating example of precise drug design overcoming specific resistance mechanisms. Even if the drug itself isn't widely available anymore, it just reminds us of that constant evolutionary pressure antibiotics face.
Now let's group together neomycin, kanamycin, and paramomycin. These three agents share broadly similar pharmacologic properties within the aminoglycoside class. Their antimicrobial activity covers both gram-positives and gram-negatives and some mycobacteria. However, Pseudomonas aeruginosa and Streptococci are generally resistant to this specific group. Their mechanisms of action and resistance are the same general principles we've discussed for the whole class. It's a critical historical point, though, that the once widespread use of these particular drugs, especially for bowel preparation before elective surgery, significantly contributed to selecting for and spreading resistant organisms in hospitals.
An unintended consequence of overuse.
Definitely. There's complete cross-resistance between kanamycin and neomycin, and this cross-resistance might also extend to amikacin. Pharmacokinetically, like all aminoglycosides, this group is poorly absorbed from the GI tract. When given orally, they mainly act locally to suppress susceptible gut bacteria and are then largely excreted unchanged in feces. Any tiny amount that is absorbed systemically gets eliminated by the kidneys via glomerular filtration. Their clinical uses today are quite restricted, mostly due to significant toxicity associated with giving them parenterally by injection and higher rates of resistance compared to other aminoglycosides. Neomycin, for instance, is generally limited just to topical and oral applications now. Kanamycin's systemic use is pretty much confined to treating multi-drug resistant TB, although even there, alternatives like amikacin might be preferred due to better resistance profiles. And again, kanamycin is no longer available in the USA. Parmomycin, however, holds some unique niches. It's shown effectiveness against visceral leishmaniasis when given parenterally. It can also be used topically for cutaneous leishmaniasis. And it's specifically indicated for intestinal and amoeba histolytic infections, and sometimes used for other intestinal parasitic infections.
So paromomycin has some very specific anti-parasitic uses.
Yes, quite distinct. For topical administration, neomycin solutions, 1 to 5 milligml, have been used on infected surfaces or injected into joints, the pleural cavity, or abscesses. But the total amount given this way must be strictly limited, no more than 15 milligrams per day, because systemic absorption, even topically, can cause toxicity. And honestly, the effectiveness of this kind of topical application for systemic benefit hasn't been clearly demonstrated. Ointments, often the triple antibiotic kind combining neomycin with polymyxin and bisotracin, are applied to skin lesions or maybe in the nose to suppress staph, but their efficacy for deeper infections is often limited. For oral administration, neomycin had a history in bowel prep for surgery. Typically 1 gram every 6 to 8 hours for 1 to 2 days, often with erythromycin base, to reduce aerobic gut flora. It was also used for hepatic encephalopathy, 1 gram every 6 to 8 hours with reduced protein intake to suppress gut bacteria and reduce ammonia production. But for hepatic encephalopathy, neomycin has largely been replaced by lactulose and other less toxic options. Paromomycin's oral use is mainly for those protozoal infections. When kanamycin was available for IVM use, the standard dose was 15 milliliters a day in 2-3 divided doses IV. For TB, it was 15 milliliters as a single daily IM shot. Monitoring for that once daily TB dose aimed for peaks of 35-45 milliliters and undetectable troughs. The adverse reactions for all members of the neomycin group include significant nephrotoxicity and ototoxicity. With this particular group, auditory function seems to be affected more severely than vestibular function. Deafness is a potential outcome, especially in adults with kidney problems or prolonged high drug levels. And again, that rare but serious cure like neuromuscular blockade and respiratory arrest from sudden peritoneal absorption of kanamycin, with calcium gluconate and neostigmine as the antidotes. Lastly, the topical neomycin ointments can cause local irritation or allergic reactions.
This group really illustrates how older drugs, even those with significant toxicities, can still hold very specific, albeit limited, roles. Often it's due to unique properties like their poor oral absorption being leveraged for gut decontamination, for example. It's about using their precise characteristics for targeted applications where the benefit outweighs the risk.
Now let's discuss plazomicin. This represents a really significant stride forward in our fight against some of the most challenging drug-resistant pathogens we face today. Plazomicin is the newest aminoglycoside to gain FDA approval, specifically for treating complicated urinary tract infections, CUTI, including pyelonephritis. It's a synthetic molecule derived from sacomycin, an older aminoglycoside that's no longer available. What makes plazomicin so innovative are its specific engineered structural modifications. These precise alterations have created a compound that's significantly less susceptible to most of those aminoglycoside-modifying enzymes produced by resistant bacteria.
So it evades the common resistance mechanisms.
Exactly, that's its core advantage. This allows plazomicin to retain robust activity against many pathogens that are resistant to other aminoglycosides. It shows potent in vitro activity against Enterobacterales. And impressively, it exhibits 2 to 4-fold lower minimum inhibitory concentrations, MICs, against non-fermenting gram-negative bacilli like Pseudomonas aeruginosa compared to gentamicin, tobramycin, and amikacin. Its activity against staph is similar to gentamicin's. In terms of its pharmacokinetics and dosing strategy, plazomicin really stands out. It's given as a single daily 15 milligram intravenous dose infused over 30-60 minutes. This dose yields pretty high mean peak concentrations, around 113 milli-TNOL, but impressively low trough concentrations, averaging about 0.43 milli-CGML. Its half-life is roughly 3 to 4 hours. Crucially, and this is a significant deviation from other aminoglycosides, traditional twice or thrice daily regimens are not recommended for plazomicin, not even in patients with impaired renal function.
Only once daily for plazomicin, period.
That's how it was studied and approved. This unique approach simplifies its use and minimizes those peak-trough fluctuations. As a result, therapeutic drug monitoring for plazomicin is also more straightforward. It only requires monitoring of trough levels rather than both peak and trough. The target trough level is less than 3 millisig/ml. This is to prevent nephrotoxicity, as higher trough levels seem to correlate with increased kidney-related adverse events. Patients with impaired renal function, specifically an estimated creatinine clearance less than 60 millimin, are likely to need dose adjustments. And these monitoring parameters are most applicable when treating its FDA-approved indication, complicated UTIs. Whether different targets might be needed for off-label uses is still an area for further study. Clinical trials for plazomicin have shown some really promising results, particularly in areas of high unmet need. A key phase 3 trial compared plazomicin to meropenem for treating cUTI, including pyelonephritis. It demonstrated clinical non-inferiority. What really highlights plazomicin's value here is that about 30% of the participants in this trial had infections caused by organisms resistant to at least one agent in at least 3 different antibacterial classes. So it worked against truly multi-drug resistant bugs.
That's impressive.
Very. An additional smaller phase 3 trial specifically compared plazomicin to colistin, another powerful last resort antibiotic in combination regimens for various infections caused by carbapenem-resistant Enterobacterales, or CRE. These are some of the scariest bugs out there. The primary outcome, a composite of death and disease-related complications at 28 days, occurred in significantly fewer patients who got plazomicin, about 24%, compared to those who got colistin, about 50%. Importantly, there were also lower rates of acute kidney injury with plazomicin compared to colistin. Now, while the data are limited due to the trial size, they strongly suggest that plazomicin could be a highly valuable alternative for patients with critically few treatment options left due to severe drug resistance. Regarding its toxicity profile, given its relatively recent approval, it's still a bit unclear whether plazomycin's long-term profile will be entirely similar to the older aminoglycosides. As we mentioned, no ototoxicity or nephrotoxicity was seen in its early trials. However, that phase 3 trial did report higher rates of renal-related adverse effects with plazomicin compared to meropenem, 3.6% to 1.3%. But the crucial positive finding was that most participants who experienced nephrotoxicity with plazomicin had full renal recovery by their final follow-up. So it's this balance, promising efficacy against tough resistance, coupled with a nuanced and seemingly more recoverable renal toxicity profile that's vital for its future use and continued monitoring.
Plazomicin really is a shining example of ongoing targeted innovation in antibiotic development, specifically addressing that ever-growing, frankly terrifying challenge of drug resistance. It offers genuine new hope in a critical area of medicine where our options have been dwindling really rapidly.
And finally, let's briefly turn our attention to spectinomycin. This is an antibiotic that, while often sort of broadly associated with aminoglycosides, is structurally quite distinct. It's categorized as an aminocyclitol antibiotic. Structurally, spectinomycin is related, but it fundamentally differs in lacking those characteristic amino sugars and glycosidic bonds found in true aminoglycosides. In terms of activity, it's active in vitro against many gram-positive and gram-negative organisms. However, its clinical use was almost exclusively confined to a very specific niche, as an alternative treatment for drug-resistant gonorrhea or for treating gonorrhea in patients allergic to penicillin. Most gonococcal isolates were inhibited by concentrations around 6 millisig/ml.
So mainly for gonorrhea.
Almost solely. And while gonococcal strains could develop resistance to spectinomycin, a key advantage was that there was notably no cross-resistance with other drugs commonly used for gonorrhea. That made it a valuable last-line option back then. However, it had a crucial limitation. It was not recommended for treating pharyngeal throat gonorrhea infections. Failure rates were persistently high for throat infections, regardless of its in vitro susceptibility. Spectinomycin is rapidly absorbed after intramuscular injection. The standard regimen for gonorrhea was typically a single IM dose of 2 to 4 grams or 40 milligograms in children. In terms of adverse effects, pain at the injection site was common. Fever and nausea could occasionally occur. More serious but rare adverse effects included nephrotoxicity and anemia. And similar to nettlemycin and kanamycin, it's important to note that spectinomycin is also no longer available for use in the USA. Just underscores how the antibiotic landscape changes over time.
So spectinomycin, even though it's not available here anymore, stands as this fascinating historical example of a highly specialized tool, a drug with a very narrow yet critical purpose, particularly for patients with specific allergies or facing certain resistance patterns. Wow, what a truly profound deep dive this has been. We started by dissecting the very essence of these incredible, powerful antibiotics. We meticulously peeled back the layers to understand their complex molecular mechanisms of action. We explored how bacteria ingeniously fight back with resistance strategies. And we looked precisely at how we carefully dose and monitor these drugs to constantly balance that efficacy with safety.
Yeah, and if we connect this back to the bigger picture, you've really seen today how understanding intricate chemical structures, precise pharmacokinetics, and even those relentless evolutionary strategies of bacteria, how they're all inextricably intertwined to effectively combat serious infections. You've truly explored this topic with the depth and critical perspective needed by an elite professional in this field.
Absolutely. And just to recap some of the essential takeaways that you've really mastered today. Aminoglycosides are powerful bactericidal protein synthesis inhibitors, their main target. Aerobic gram-negative bacteria. Their unique properties, that concentration-dependent killing and the significant post-antibiotic effect, are the scientific underpinnings for favoring once-daily dosing. A strategy proven just as effective and demonstrably less toxic, especially regarding nephrotoxicity, compared to the older multiple-dose regimens. We've also really driven home that ototoxicity, often irreversible ear damage, and nephrotoxicity, frequently reversible kidney damage, are the major class-wide concerns. They demand vigilant monitoring of kidney function and precise drug levels. You now understand that each specific aminoglycoside carries its own nuanced profile, its spectrum, resistance patterns, specific clinical uses, and they're almost always employed strategically in combination with other antibiotics to maximize efficacy and minimize resistance development. And finally, we discussed plazomicin, representing an exciting and crucial new development, offering much-needed hope against those scary, multi-drug-resistant pathogens. And spectinomycin, which, though no longer available in the U.S., highlighted how highly unique structural properties can lead to very specialized and critical clinical roles within our historical pharmacopoeia. As we wrap up this deep dive, maybe consider this: in an era of just escalating antibiotic resistance, understanding this intricate, often counterintuitive dance between these powerful drugs and the constantly evolving bacteria they target. It isn't merely about memorizing facts, is it? It's really about appreciating the continuous innovation, the meticulous scientific inquiry, and the profound clinical vigilance required in medicine just to stay one step ahead in this perpetual biological arms race. What does the future of antibiotic development truly look like, given these complex challenges and the breakthroughs we continue to witness? It's a question that continues to drive researchers and clinicians alike, constantly pushing the boundaries of what's possible. That's all for this deep dive. We hope you feel more than just informed. We genuinely hope you feel truly empowered by this knowledge. Until next time, keep exploring, keep learning,